Hey guys, it's me again, Callie. In keeping with our new to the ICU material, I wanted to go a little more in depth and something that can be quite complex. And I brought myself a friend. His name is Sam. I'll let him introduce himself though.
Hey guys, so I actually met Callie through a organization that I am the HEMS director for called Every Coast Helicopter Operations, but she's actually part of our future flight crew program because eventually we're going to get her riding around on a helicopter with me. But she just happened to actually be on a contract to Baltimore. I don't know if you said that in your last video, but you're actually on a travel nursing contract to Baltimore where I work. So I work at Johns Hopkins. I'm a critical care transport nurse, and I've been doing that for 10 years now. Yeah, about 10 years now. I've been a nurse for about 15, um, mostly all ICU, and ER, ICU, and transport. Actually, the vast majority of it, all but 4 years transport. Um, I actually gave a presentation recently about the fact that I have pretty much spent my entire career in a non-traditional nursing um, climate, I guess you could say. I spent the first 5 years of my nursing career on active duty with the military. So deployed and in sort of a non-traditional format. So as a result of that, I have between transport and then sort of the non-traditional setup, I've had to learn a lot of things that are a lot of times outside the purview of nurses. One of which is mechanical ventilation. Here in Baltimore, I work for Johns Hopkins now, but used to work for University of Maryland, who has a huge ECMO program. And we used to take care of a lot of really, really sick lungs, which just basically forced me to learn mechanical ventilation pretty much through sheer brute force. Like I just kind of was forced to learn it. So that's why Callie kind of recruited me along on this, on her insta-ICU nurse quest here.
Yes.
Um, we're not gonna go really in depth on ventilators, but um, the goal is to give you a basic understanding of what the ventilator is doing, how it's doing it, when you should be concerned, how you can handle some troubleshooting on your own without the respiratory therapist, but most importantly, when you need to call the respiratory therapist or when you need to call for help. Because the respiratory therapist can be one of the most valuable assets that we have in the ICU. Um, the problem that's going on now is that we're short on them, right? So there's only, just like we're short on nurses and they're having IMC and floor nurses work in the ICU. There's a couple of places that I know of that anesthesia residents and CRNAs are acting as respiratory therapists because we just don't have enough.
Mhm.
So that's sort of why Callie reached out and wanted me to come along on this journey. I teach pretty extensively on mechanical ventilation, both to transport environment and I've taught a couple times to ICU nurses to kind of give them this format, but we're gonna go into some specific things and kind of boil it down. So
Perfect.
that's kind of the plan for today.
Well, thanks for being here.
Yeah, absolutely.
So, mechanical ventilation, when you look at your vent in the first place, there are a bunch of abbreviations on there that are important to know. So what are the most important abbreviations to know, or all of them?
Yeah, so this is the fun part. When it comes to modes, all the ICU or all the ICU ventilator, all the ventilator manufacturers got together and said, how can we make this as complicated as possible? They all decided they're going to name the same mode something different on their ventilator. Um,
Right.
so that's the hard thing. And so my advice to you would be to focus on sort of some basics um, and focus on we're going to pop a PowerPoint presentation, a couple pieces of a PowerPoint presentation up that I've done
And you bring up a good
in the
point there, because part of the
past.
problem with this COVID pandemic is that we have had to bring in a bunch of transport vents. You're having vents come from everywhere. So even if you're in a place that's used to having one type of ventilator, you might be seeing many different types, even just in one ICU.
Yeah, absolutely. I mean, I know of, particularly at Hopkins, I know they went out and bought, I think it's 60 new
Yeah.
ventilators when this whole thing kicked off, and they were super familiar to me because they were the in-house version of our transport ventilator, but not super familiar to, and probably 100% unfamiliar to any of the ICU nurses, because
Hmm.
those ventilators are just not used in the ICU. They're similar to to Hamilton's bigger ventilator, but they're not. They're in a little tiny box, and they're maybe the size of a. Trying to think of a piece of equipment that's roughly that
It's like a
size,
big shoebox.
like a big shoebox. Yeah, yeah. I mean, I can compare it to other transport equipment, but I was trying to think of something in the hospital,
Yeah.
like I don't know, two tube feed pumps together, like that size. They're not
Yeah.
huge. Um, Actually, the best thing to kind of compare it to is probably the defibrillator that's on top of your crash cart. It's about that size, um, and so it looks very different than all the other ICU ventilators out there. So the stuff's all in different places, and Hamilton has named their modes something different than Draeger or something different than Servo or Puritan Bennett. Um, so that kind of makes everything that much more difficult.
Right.
So we're going to kind of pop down here. So you basically, Callie, you can see that, right? I'm just making sure that,
Yes.
okay.
Yes.
So you basically have 7 basic choices with the ventilator. You get to decide whether it's AC or SIMV, pressure versus volume. So how the breath gets delivered, you get to decide how many times the breath is delivered per minute, the time over which that breath is delivered, which is the I time or the inspiratory time. You're deciding a pressure control or a tidal volume, PEEP, and FiO2. And we're not going to get into all of these today, but we're going to try and kind of understand a few of them, so that you can kind of understand what's going on with the ventilator. Um,
Perfect.
and so on that, I'm going to stop sharing, and we'll pop back and forth to this slide deck. But sort of on that note, we'll go into a couple of the basic abbreviations that you're going to see on almost every ventilator. And you're always going to see rate. You're always going to see tidal volume, which may be abbreviated VTE or VTI. One is an inspiratory tidal volume, VTI is an inspiratory tidal volume, and VTE is an expiratory tidal volume. Most ventilators, you want to look at what your expiratory tidal volume is. You're going to see minute ventilation or MVE, which is minute volume exhaled, is sort of what that stands for. Peak inspiratory pressure, and these are going to be pretty much on every ventilator and abbreviated this way. Peak inspiratory pressure, or PIP. You're going to see PEEP. You'll see a lot of times you'll see MAP, so a mean airway pressure, very similar to your mean arterial pressure. And when we teach ventilation and oxygenation, we'll kind of talk about them similarly. I kind of equate them. When we get into some of the advanced modes, you may see APRV or things like that. We're relying on the mean airway pressure very similarly to the way you're relying on mean arterial pressure. Where it gets more complicated is the modes. And like I said, we want to focus on whether it's an AC or an SIMV style mode, and we'll explain sort of what that means in a few minutes, or a pressure or a volume mode. And you're going to see anything from VCAC, PCAC. I'm trying to think what some of the other ones are. You'll see a PRVC style mode. You might see CMV, SIMV plus, CMV plus, duo PAP, bi-level, bi-vent. And then you'll see VCAC, and they all basically boil down to either an AC or an SIMV style mode, or a pressure versus a volume mode. And I'm going to show you some waveforms, because all the ICU ventilators, unless it's unless they're scraping the bottom of the barrel and getting ventilators that have no waveform, almost every ventilator I'm aware of these days, to include that transport ventilator I was talking about, has waveform on it, and you can go in and you can look at the waveform and tell how the ventilator is delivering the gas. One of the things I said to Callie was, really all we do with the ventilator is we control flow. We control how often you get the flow, when you get the flow, for how long you get the flow, what triggers the flow, what stops the flow. It all comes down to controlling the flow of gas. So every ventilator, all a ventilator is a fan that turns flow on and turns it off. And it modulates how that flow is delivered, how fast and when and how often. But it all boils down to that. That sort of didn't answer your question, but that's the best I can do for now.
No, that's good.
Short of like going through each ventilator and saying, okay, this is what this means on this ventilator. But abbreviations wise, you're always going to see sort of those readings that you're going to get back. And the really important ones are peak inspiratory pressure.
That's your PIP, which would be
PIP.
abbreviated as.
Yep. And that's most likely going to be the top big number on every ventilator. And arguably PIP, depending on the mode you're in, is a useful or a not useful number. There's something called plateau pressure, which is a much more useful number. PIP is a number that has a lot of artifact in it, in that if your ET tube is small, you have reactive airway disease, you have mucus plugging, the tube is kinked, they're biting the tube, whatever. PIP gets kind of dirtied up, and it will look higher because of those things. So if I intubate you, Callie, and I put an 8.0 tube in you, your PIP is going to be lower than if I were to put a 6.0 tube in you. Only because I'm having to push the gas. Yeah, I'm having to push the gas through a smaller straw, smaller McDonald's straw, right? Because let's be honest, all we're doing is cramming McDonald's straws between people's vocal cords. I spent a lot of time learning how to do that, but that's really what it boils down to. McDonald's straws and garden hoses and house fans. That's pretty much all it is.
House fans. It's fantastic.
Or a compressor, if you want to think about it that way, like a compressor that we use to power nail guns.
God.
But yeah, so those are the big ones. So peak inspiratory pressure, your minute ventilation is super important, and your tidal volume are important. And we'll talk a little bit about why those are important when we talk about sort of what modifies oxygenation versus ventilation and why those are important concepts to understand. But those are the big important things that you want to be able to look at on your ventilator and kind of have an understanding of where they were when you started your shift and kind of how they've trended, right? Because they can go up and down for short periods of time and whatever, fine. The patient's coughing, their peak inspiratory pressure goes through the roof. But if your peak inspiratory pressure is slowly climbing over the course of your shift and your tidal volumes are down over the course of a period of time, or your minute ventilation is down over the course of down or up, over the course of time, that gives you some information about what's going on with your patient.
Right. And I would say it's almost as important to trend that as you're training the rest of your vital signs.
Oh, absolutely. And the respiratory therapist in theory is trending those, but the respiratory therapist has 15 patients.
Right.
You've got one, maybe two. And so it's a little easier for you to say, this has been going up, this has been going down, and say it to the respiratory therapist, like, this has been changing. I don't know if you've noticed that, and kind of draw their attention to it, or the doc or something like that.
Yeah, because that's another important point. When there's not as many respiratory therapists, we're the person in the room that's there to fix things and watch the trends.
As an ICU nurse, I always felt like my job was to be the eyes and ears of the providers. Like, exactly, the providers got an entire unit and they can't keep an eye on everything. So they're relying on you to bring their attention to things that are changing, right? They see the patient, they're looking at Epic, sure, at trends, but sometimes those can be misleading. And sometimes, like, what do you do? Vitals every hour? Like, a lot can change in an hour. So, like,
that's true.
A lot can change in an hour. So that's sort of how I've always looked at it.
So back to these modes.
Sure.
We talked about how all the ventilators are confusing and there's 5 million different ones. What are the ones that I care about and why do I care about them?
So the big ones, like I said, we'll kind of talk about AC versus SIMV and then pressure versus volume. And
Perfect.
those are every mode that's on any ventilator is a version of one of those two modes. Somebody may argue with you and they can argue with me all they want, but at its most core, like at its most basic level, they're either a pressure mode or a volume mode, and they're either an AC or an SIMV style ventilation. So the first thing we'll talk about is, and I shot some videos the other night, is, let's do some screen sharing here. I can find the buttons that I want. All right. That's back up, right?
Yes.
Okay. Our production value is not super high on this, just for the record, whoever's watching this.
Fantastic.
There's a lot of like, is it working? So AC versus SAMV and pressure versus volume. So we're going to talk briefly about AC versus SIMV. Let me run this back. So this is a test lung on an LTV. And
which is a type of ventilator.
Yes, sorry. It's a good thing we brought you along, Callie.
I got you.
Which is a type of, it's an old, and it's actually still very pretty popularly used transport and nursing home ventilator and like home ventilator. We see a lot of people come in on this. It's the F-150 of ventilators. It is darn near bulletproof. It works great, not super sophisticated, but it does a great job with what we ask it to do. So you can see this is, I think I had the rate set at 12 and 500 cc's. So pretty basic, 12 and 500 cc. So this is me triggering the ventilator essentially. So when I don't mess with it, this is a paralyzed, heavily sedated patient, right? The ventilator is going to breathe at a rate of 12. There's no interaction from the patient. And that's me taking a patient breath. And you'll notice this is an AC mode. All right, so every time I trigger the ventilator, it gives the same breath, right? So what we're doing with AC and SIMV is we're defining how the ventilator interacts to the patient. So when the patient takes a breath, how does the ventilator interact with them? And in an AC mode, every time the breath is delivered, whether it's a machine-initiated breath or a patient-initiated breath, it's the same settings. So if you're in a volume mode, it's the same volume over the same inspiratory time. So it's the same breath every time, whether it's patient-initiated or machine-initiated. And then we're going to switch to SIMV. So in SIMV, once again, we're determining how the patient interacts with the ventilator. So now I'm triggering the ventilator, and you'll notice we get a little breath, and another little breath, and then a big breath, and then a little breath, and then a little breath, a little breath, another little breath, one more little breath, and then a big breath. So what you're doing with SIMV is you're saying, I'm going to guarantee you X number of full support breaths or full volume breaths if you're in volume ventilation, and then you can take what you want in between. So a paralyzed patient or a heavily sedated patient on SIMV might as well be in AC because they're not interacting with the ventilator, right? It's still going to give them, let's say we're set at a rate of 12 and 500 cc's. It's going to give them 12 breaths a minute at 500 cc's. But in SIMV, we dial in a pressure support. It's usually 8, 10, 12 centimeters of water pressure. And so they're going to be given that support for those little patient-initiated breaths. And the volume is going to be completely dependent on what they pull. So SIMV was designed as a way to get people off the ventilator. So what you would do is you would match their support. So 12 and 500, and then every breath they took, let's say they were requiring 25 centimeters of water pressure to get that 500 cc breath. Right off the first, we would set them with a pressure support of 25, and then we slowly decrease their pressure support. And
so they're working harder and harder.
Yep. And then so they're having to do more and more of the work, and then you take their rate down, and eventually you're on a rate of 5 and 5 of pressure support, where the patient's essentially doing
breathing.
all the work.
Yeah.
Or you just transition to pressure support. A lot of places don't hang on to SIMV that long, and they just transition their patient at some point to pressure support, CPAP plus pressure support, and then there's no rate, where they just let them do the work.
So in a situation, I'll let you get back to the video in a second,
Yeah.
But in a situation where we're in with COVID, where we're running out of sedation, and so some of these patients, if they can tolerate it, we're not sedating them very heavily to the RASS of -4, -3. We're trying for -1, like just slightly drowsy. So for those patients, the mode that would be more appropriate would definitely be this SIMV mode, because most people are going to want to breathe when they want to breathe, right?
Yes. So yeah, with these patients, and we'll get into pressure versus volume in just a minute here, but I would definitely spontaneously breathing patients. So somebody who's only got a RAS of 0 or -1, they're going to want pressure because they get to decide type of breath they want, and they're going to want an SIMV mode because they get more freedom, and they get to decide how they're going to get their breaths and when they're going to get their breaths. So yes, SIMV is a better mode in those patients. And I say that with a caveat of it's a better mode as long as they don't need to be more appropriately sedated for their disease process.
That
right?
makes sense. Yeah.
You're doing a lot more work. Your metabolic demand is going to be much higher. There's a lot of other things that come along with the patient doing the work that may not be appropriate. COVID, no COVID, whatever. The patient doing more work sometimes isn't a good thing. That's my only caveat on that.
It makes sense.
So more SIMV. Test lung fell off the table at this point. All right. So this is volume ventilation. So you'll be able to see the difference, and I'll show you some graphs here in just a second, but visually this is volume ventilation. Well, that gets disconnected. That's a ventilator alarm. So volume ventilation, and I'm hyper exaggerating the inspiratory time here so that you can kind of see. I'm hyper exaggerating how long or how volume works. So volume ventilation puts the breath in over the course of your inspiratory time. So if you have a 1 second inspiratory time, it gives the breath over 1 second. And this is a 2 or 2.5 second inspiratory time. So it's giving that 500 cc breath over 2 seconds. So you can see it's very slow in, and this will make more sense when we look at it graphically on the graphics on a ventilator. You're going to see now I just changed to pressure. So now you see the breath go in, hold, and then drop. It goes in much more rapidly, holds, and then drops. So this is still a 2 second I time. All I did was change from pressure to volume, or from volume to pressure. So it goes in and holds and then drops. So the flow is front loaded. Like I said, all we do with the ventilator is we control flow. So the flow on here is front loaded on pressure. So let me show you. So this is a pressure mode, and you can see almost every ventilator is going to have the graphics in roughly the same place. This is the
Mhm.
Draeger ventilator, and you can see these are those abbreviations that I was talking about on the far right. I don't know if you guys can see my cursor
Yeah,
on this far right. You can see the abbreviations,
that's perfect.
and then so we'll back up to kind of your first question, and I didn't even think about kind of doing this way. But on your ventilator, you've got essentially two sets of abbreviations and two sets of numbers. You have the sets of numbers that you set. So down the bottom on the Draeger is the numbers, and the servo's the same way. The numbers, I believe, are on the bottom. Um, these are the numbers we set. So we set an FiO2, we set an inspiratory pressure, we set an inspiratory time, we set a rate, we set a PEEP, and then slope is a measure of how quickly it goes up. So we won't get into that. And then these numbers are the numbers you're getting back from your patient. So these same numbers on the bottom could give you completely different numbers over here, depending on the patient.
And you'll know the difference because the ones on the bottom aren't changing. So even if you
Yep.
have like a different vent and they're on the side or whatever, if there even is a vent like that, you'll know the ones that were set are the ones that don't change at all, right?
Yeah, actually the Hamilton, the numbers are kind of backwards. You have numbers on the far right that are the settings, and then the far left along the side, kind of like where these numbers are, but over
Mm-hmm.
here are the numbers you're getting back off the ventilator. Might actually be able to show that to you guys at some point, but really what we were trying to get at here is the reason I first popped this slide up was pressure versus volume. So this is a pressure mode. So pressure CMV. So this is a pressure AC. So it's a pressure control AC mode where pressure goes straight up, and this is your pressure wave or your pressure waveform and your flow waveform. And you'll see the pressure waveform go straight up, square off, and then drop. And you saw that with the test lung where the breath went in, it held, and then it dropped. And the reason for that is the flow is front loaded. So the ventilator turns the flow on at what looks like about 80 liters a minute, 75, 80 liters a minute, until it hits the 15 or the 20 that we've set. It goes to 20 and then turns the flow off and it decelerates. So it's what's called a decelerating waveform. So it turns the flow on straight away until it gets to the pressure that it wants, and then it drops off. Versus,
So patient breathes in really quick and then lets out.
yep. Well, they breathe in really quick, they hold their breath, and then they exhale, which sounds a lot less comfortable than it actually is. Most patients really enjoy being able to take their breath because they don't have to breathe in that fast. They're controlling how fast they breathe in by just allowing that flow. So the big difference here in volume, and we saw this in the test lung, was in a volume ventilation, the ventilator says you wanted 500 cc's, right? So we set a 500 cc tidal volume and an I time of 1 second. And the ventilator says, okay, I need to give 500 cc's and I need to give it over 1 second. So I need to blow at 30 liters per minute. So the ventilator turns on flow at 30 liters a minute for 1 second, which gives you your 500 cc's. And you can see the pressure goes, it climbs and climbs and climbs and climbs until it hits that 500 cc's, until the flow hits that 500 cc's, and then it opens the exhalation valve. So you could walk into a room and they could have put tape all over the entire ventilator except for the waveforms, and you could be able to tell how the gas is being delivered to that patient just by looking at their pressure and their flow waveforms. So it all comes down to flow. It's front-loaded flow versus continuous flow over the course of the breath. Does that make sense?
It does, yes.
Okay.
That way you don't have to ask your respiratory therapist who probably isn't in the room, or the nurse before you who probably didn't even know whether the patient was on volume control or pressure control. You can actually go in and look at your vent yourself and know how your patient's being managed.
And the one thing that I will caution you about is that a lot of ICU ventilators have the ability to modify these things from these traditional styles. So a lot
So it
of
may not be
ventilators,
as clear cut.
it may not be, well, it's clear cut if you look at your waveforms, but if you start reading like the top of this, like if I think the Draeger has the ability to do this, where I could change the flow into a decelerating waveform, where this will say VCAC at the top, so an AC volume control.
Yeah.
But I can change the flow to where I get a decelerating waveform where it looks like a pressure control ventilation, where the flow is being delivered as a pressure control ventilation. So look at your waveforms. That will tell you what's happening and how the gas is being delivered.
So then, are these all the modes that we care about?
Yeah, so there's one more mode that we care about, and it's PRVC. We tend to see PRVC a lot these days. So it's sort of the best of both worlds. And this is one way that PRVC is done. So PRVC stands for pressure regulated volume control. And it's called a couple different things on different ventilators. The Draeger just calls it auto flow, and you can be in either mode. Like it'll say VCAC at the top, but then it'll say auto flow underneath of it, and it's a PRVC style mode. And really what it comes down to is it's a pressure mode. So in the classification of volume versus pressure, it's a pressure mode. Mm-hmm. So this is how one ventilator does it. Other ventilators do it a little bit differently, but this particular ventilator gives a volume breath at whatever you set it at. So it's a pressure mode with a volume goal. So you say, I want 500 cc's. So that first breath is a 500 cc breath, right? So it gives a 500 cc breath, and it says, how much pressure did I need to deliver that 500 cc breath? So it delivers the next breath, and the next breath is, let's say this took 25 centimeters of water pressure to deliver. The next breath is going to be a 25 centimeter water pressure breath. And it's going to say, okay, well, how much volume did I get off of that? And if it got 500 cc's, it stays at 25 centimeters of water pressure. But in this analogy, it got 550, or in this example, it got 550. So it dropped it down. So it will go up or down a total of 3. Most of them will limit it to 3 centimeters of water pressure. So in this case, 500 cc volume breath gave you 25 centimeters of water pressure. It gives a 25 centimeter water pressure breath, which gives you 550 cc's. So then it drops it to 22 centimeters of water pressure. And it says, okay, that gave me my 500. So the next one is going to be a 22 centimeter water pressure breath. And then this one's going to be a 22 centimeter water pressure breath. But this one comes back at 450. So it says the next one needs to be higher. So it adapts breath to breath for a tidal volume goal.
So much more adaptive mode.
It is a much more adaptive mode. And it's actually a really, really good mode for a lot of patients. And I say a lot of patients because there's never an answer that works for every patient, right? Unfortunately, there's no silver bullet. So PRVC is a great mode for most patients that are settled and are comfortable on the ventilator and are not in the acute phase of their illness. Because what can end up happening is if they aren't well sedated or they're super dynamic, they end up all over the place with PRVC and it can't catch up fast enough. And it either ends up overventilating them, underventilating them, making them do a lot of that work. And you can have an SIMV or an AC version of PRVC. Does that make sense?
Yeah, it does. Okay.
So it's really a volume goal, which is great, right? It's a little bit safer in that it will adapt to the patient and not over pressurize them or give them too much volume or too little volume based on what's going on. Because the big drawback to pressure is I set a pressure and we never know what that pressure is going to be on every patient. So we see pressure control a lot in kids because you can give me and my 4-year-old the exact same ventilator settings from a pressure control standpoint, and we're both going to be okay because the volume is going to be dependent on the container that we're putting it into. So you could put both of us on 25 centimeters of water pressure, and my tidal volume is going to be 450, 500, and his is going to be 140 or 150. So that's the drawback, right? Because if I put somebody on pure pressure control and the compliance changes, their lungs get worse or their lungs get a lot better, their tidal volume either goes up or down based on that pressure.
That makes sense.
Versus volume sort of is the other way around. I say, I want 500 cc's of gas, and the pressure is going to be dependent. So if their lungs get better or worse, their PIPs go up or down. And we're really concerned about them going up, right? As their compliance gets worse, their PIPs go up or their plateau pressures go up, because now you're trying to take that same volume of gas and cram it into a smaller container.
That makes sense. So what about when we walk in and see our patients on this pressure support mode or our CPAP mode? What is important to know about that?
So the big thing there is that typically means your patient's getting better, like they're doing the work. So those modes, really what you're looking at is how much pressure support are they on, and then where's their PEEP. So you're only getting really 2 pressures in that situation. It's BiPAP, right? So it's essentially
BiPAP through tube.
It's BiPAP through a tube, exactly. So it's essentially BiPAP.
We haven't really talked about PEEP yet. I mean, we've said the word, but if we're an ICU nurse who's never been ICU nurse before, that's your positive end expiratory pressure. And that kind of leads us into my next question.
Sure.
Is how does this all relate to my patient? Like, how does this make my patient better? Why does a ventilator fix them at all?
Yeah. To finish out your last question, the one thing I would say, no, you're fine. The one thing I would say is you need to keep an eye on your pressure support patient. And this is where some of those other alarms come in and those numbers that you're trending become important. If they start failing that, right, they start getting worse, they start tiring out, you want to make sure that you're keeping an eye on their minute ventilation and their tidal volumes, because you're going to see them trend down. Because with that mode, they're doing all the work. We're giving them a little bit of support, but they're doing all the work. If their respiratory rate drops off or they stop pulling as hard, their volumes are going to go down and they're going to become more acidotic, more hypercapnic, not oxygenated as well. So that would be the only thing that I would say with the pressure support. If you walk in and your patient's on pressure support, great, they're starting to get better. But that doesn't mean that you can it actually means that you probably need to pay closer attention to them, because the ventilator, while all of them have apnea backups, and if the patient goes apneic, they will kick over. They a lot of times don't, the alarms aren't set real tight for good reason, because you don't want a bunch of nuisance alarms. But as their minute ventilation and their tidal volume start to drop off, the ventilator's not going to care until they go completely apneic, right? It's not going to actually alarm or kick over until they go apneic. And they have to be apneic for most ventilators, they have to be apneic for 20 seconds, 20 plus seconds for it to kick over in the apnea, which is fine. But if they've been trending down that whole time, they're already in a pretty deep hole. And you need to be kind of acutely aware of what's going on with that and why they're doing that.
I like your analogy for the BiPAP, because it makes a lot of sense, especially if you sat on a sick BiPAP patient in IMCU. It's the same thing. Like, normally you're trying to avoid getting them intubated, and you do have to keep an eye on their gases and their work of breathing and all that jazz.
Yeah, I genuinely believe that a sick BiPAP patient is they're much scarier than the intubated patient. Right, because the intubated patient, I've got full control. The sick BiPAP patient, like, we're just waiting for them to fail or succeed. So it's like, you're sitting on the edge of your seat going, is it going to work? Is it going to work? Is it going to work?
Mm-hmm.
And I did a lot of that, and you probably did too, as a rapid response nurse. Like, you
Yeah.
go to the floor and they're like, let's do a BiPAP trial, which is great. I fully support BiPAP trials, but those are the patients that go one way or the other.
Right.
And they a lot of times need even closer monitoring than the patient who's on ECMO or on like sick APRV or like these really, really profoundly sick patients from a respiratory standpoint, because we're in control at that point versus like we're trusting that the patient's either going to get better. We're kind of on that precipice of like, are they going to get better? Are they not going to get better? So
Mm-hmm.
while CPAP plus pressure support, or that patient who's on pressure support usually is getting better, they're that patient who could go one way or the other.
Makes sense. So now,
Yeah.
back to my question.
Yeah.
On this, how does this all relate to my patient? Why does the ventilator even help at anything other
So
than
the
just
ventilator
breathing for my
basically
patient?
does two things, right? So the only two things we really control with the ventilator are oxygenation or ventilation. And you can kind of break the ventilator into you can break the ventilator settings into two different blocks: the stuff that controls oxygenation and the stuff that controls ventilation. And the stuff that controls ventilation, which is your CO2 clearance, is rate and tidal volume. And if you take rate and tidal volume and you multiply them by each other, you get minute ventilation. And I like to think about minute ventilation as probably the most important thing on the ventilator.
Okay.
Because I can set your rate at 10 and your tidal volume at a liter, and you get a 10-liter minute ventilation. Or I can set your rate at 20 and your tidal volume at 500, which is much more appropriate than 10 and a liter, and I still get a 10-liter minute ventilation. So minute ventilation, hopefully I'm doing that math right. Minute ventilation is the algorithm of those, or kind of those two things coming together. So I tend to pay much more attention to minute ventilation than I do rate or tidal volume, because minute ventilation gives me a more global picture. But you can adjust somebody's ventilation status. So you can adjust their CO2 clearance, their PA CO2 on their gas, their end tidal CO2 on the monitor with those two. And depending on what's going on with the patient, I tend to pick one over the other. Or your doc will pick one over the other. If they're already sort of on the high end of peak inspiratory pressure, then I tend to use more rate. And we're not going to get deep into it today, but you'll see a lot more patients on lower rates and lower tidal volumes and higher rates because of something called ARDSNet and the ARDSNet studies that basically said patients do much better with lower rates and lower volumes and higher rates. So we tend not to want to go with high volumes on people. And there's always caveats to this. Like I said, I can talk till I'm blue in the face, but I'm never going to be able to answer every single scenario.
Right.
Every patient is a little bit different. But for the most part, we tend to want to keep the tidal volumes on the lower side and use rate to clear CO2. Does that sort of answer the ventilation side?
Yes.
Okay.
It does. Yeah.
So on the opposite side is oxygenation. And we really can control oxygenation with two dials on the ventilator. FiO2, of course, right? So if we give people more oxygen molecules, we can make they can make them oxygenate better. That has some detriment. It has some major detriment. So turning somebody up to 100% FiO2 will make their SAT go up, but they will develop hyperoxia, which develops oxygen-free radicals, which causes a lot of other inflammatory issues in the body. So we tend to only want to give people as much oxygen as they absolutely need to maintain their oxygenation. So the way we compensate for that, or the other way we oxygenate people, is PEEP. So peak end expiratory pressure. And the best way I have to describe PEEP is everybody's blowing up a balloon. And this is the classic example. Everybody's blowing up a balloon. So when you blow up a party balloon, you have to blow really hard at the beginning to get it to kind of open up. And then it gets easier, right? So PEEP is that initial push. And if I blow the air out to a point that it doesn't completely collapse, it's a lot easier for me to blow that balloon back up because I've already passed that point where I had to pop the balloon open. And so what we're trying to do with PEEP is maintain an amount of gas in the alveoli, which are the balloons of the lungs, so that they don't collapse, so that they're easier to pop back open. And that's for two reasons. Number one, we don't need as much pressure to pop them back open. And number two, when those alveoli walls kind of come together, they stick together. And then I have to pop them open. And when we pull tissue apart, it tends to not like that. It tends to get pissed off when you yank it apart. And now I'm going to yank it apart 30 times a minute, and it's going to get irritated. The other thing, if you think back to nursing school, paramedic school, whatever, or anatomy and physiology, where they said, gave you the different lung volumes. So there's expiratory reserve volume and functional residual capacity. So functional residual capacity is a combination of residual volume and expiratory reserve volume. So if you sit there while you're sitting in front of the computer and you exhale completely normally, and then you forced exhale, that's your expiratory reserve volume. And then you've got a residual volume that you can never get out of your lungs. Like no matter how hard you try, there's a volume in your lungs that you can never get out. Keep trying, you'll pass out. Like it's a fun game. But then there's expiratory reserve volume, which is what we're doing. We're replacing expiratory reserve volume or functional residual capacity, which is the combination of expiratory reserve volume and residual capacity or residual volume, with PEEP. So we set PEEP as a pressure. Typically, you'll hear people say physiologic PEEP is 5, which is not really true, because if we really had 5 of PEEP in our lungs constantly, every time we opened our mouth, air would come out. And we didn't talk about this at the beginning, but fundamentally, you're taking somebody's breathing and you're turning it on its head. You're going from negative pressure ventilation to positive pressure ventilation. So you have to kind of think about that you're changing them from essentially opening their mouth and having the atmosphere cram air down their throat versus putting a McDonald's straw between their vocal cords and then having a nail gun compressor cram air down their throat. So it's different physiology. So we put PEEP in to hold the lungs open. And as we hold the lungs open, we hold gas at the membranes. So we hold the gas at the capillary alveolar membrane so that we get gas that goes back and forth across that membrane. So if I hold more gas in there and a higher pressure, I can push more gas back and forth. So that's why PEEP helps with oxygenation. I can turn their PEEP up, and I'm going to hold pressure at the alveolar capillary membrane at a higher pressure and potentially for longer, which is going to cause oxygenation and ventilation back and forth. Does that sort of make sense?
Yes, it does.
Okay. So we did a quick video. I illustrate this concept with pig lungs. So this is a set of, if you remember in high school or probably even middle school, somebody taught you like smoking's bad. And they used pig lungs that were like dyed black. No, I mean, that's actually what these are. They sell these in like a set of 2 with like one healthy and one like black lung. And it's like, don't smoke. And it's the same people that sell like the frogs and the pigs biology class that you dissect.
I had minks, so
Did a
we
mink?
dissected
Okay.
a mink. Yeah.
Yeah.
I
Well,
don't know if they sell those too, but
they do. Yeah, 100%. Pigs, like little pigs, and all kinds of stuff. Sheep eyeballs and sheep hearts
oh,
and things like that you dissect in biology class or A&P class or whatever. But this, we're gonna do a little screen share action. This is, if I can make it come up.
I see it.
Good. All right, so this is a pig lung, and it's gonna start with 0 PEEP. Let's do play. So 0 PEEP, right? And you can see the lung goes up and then falls all the way back down.
Mm-hmm.
And then we're going to start to turn the PEEP up here. So now it's at 5 a PEEP. So you can start to see we have some areas that are we're starting to hold gas in, and we're starting to get a little bit better recruitment. We're starting to see alveoli pop open. So you start to see where it's not collapsing all the way back down. Now we're at 10 a PEEP.
That was drastic.
Well, the thing to keep in mind here is that these lungs don't have a thoracic cavity, and they sit in a Tupperware. So, and I turned it up about every 10 seconds, but you'll start to see like we're starting to recruit a lot here.
Mm-hmm.
And we're holding that recruitment. And I don't think I dumped it back to 0. But if you dump it back to 0, you essentially end up back here.
Mm.
Right. So just 1 second of me like disconnecting the ET tube. And this is where this becomes very important.
Yeah, I was going to ask you about that too, for when we get on higher PEEP.
Yeah. So when you have high PEEPs, and my rule of thumb is anything north of 10,
okay,
I clamp my tube. So I take a pair of Callie clamps and I clamp my tube anytime I'm disconnecting the ET tube. The other thing is that you want to be pretty cognizant of not disconnecting your ventilator for convenience. We all know that ICU nurse that needs their lines
on
straight,
the correct side,
on the correct side and straight and not twisted up. And they will, without thinking, want to move a line from one side to the other, and they will disconnect the ventilator and reconnect it pretty fast. Mm-hmm. Well, if they're on 15 a PEEP and you do that, you just dumped all that recruitment. And these lungs, my pig lungs, come back pretty fast. There have been times that I've disconnected somebody, or in transport, we've ended up just disconnecting, and it happens, right? So it falls off the ET tube, right? It gets pulled, or the patient coughs, or you didn't push it on hard enough, it falls off. And it's taken 20 minutes to get them back, right? Their sats will drop to the low 90s, and it'll take a good 20 minutes for them to re-recruit that alveoli.
And then you got that massive shearing force too, right?
Yep. And you now just had to shear those alveoli back open.
So you just did more damage.
Yep.
At the end of the day.
Yeah. At the end of the day, yeah, you didn't do your patient any favors. Absolutely.
But your lines are on one side of the bed, so.
But the lines are all straight.
There's that.
And their hair's washed, and they were turned and bathed. And for the record, I'm the worst ICU nurse in the world, which is why I do transport, because I have my patient for an hour and I don't have to do any of that stuff. And I love to death, and do not get me wrong, I love to death my hardcore ICU nurses that do such a good job, because they're the people I want taking care of me. If I end up in the ICU, I want somebody to wash my hair and bathe me and do all of that stuff. I just don't want to be the guy doing it. No apologies.
It's valid. There's a place for everyone in this world.
There is. That's what I love about nursing, is you can find your thing. You can absolutely find your thing in nursing. So that's how you can get oxygenation. So you'll start to see your docs will come and say, okay, we want to turn the PEEP up, or we want to turn the FiO2 down. And I know our goal with these COVID patients particularly has been an FiO2 less than 60%. And we get there by doing higher PEEPs. Now, we did discover that we were at the beginning of this maybe being a little too aggressive with PEEP, because there were some patients that they figured out that there's essentially two groups, and I won't get too in depth with this, but there's two groups of COVID patients out there, some that are recruitable and some that are not. So some of them needed PEEP, and then some of them needed just oxygen. Like, us giving them high PEEPs was not doing them any favors. We were sort of giving up the oxygen-free radical, and they weren't hyperoxygenating. That's the thing. Like, I can put you on 100% FiO2 and a lower PEEP because you're not recruitable and you're not getting the hyperoxia, so you're not getting the oxygen-free radicals. So it was sort of, it's counter to me because my goal was always to turn the FiO2 down, and I would get there by turning their PEEP up. But we do some things to look at how people are recruitable, and we're definitely not
Define
getting
recruitable. I don't know if we've defined that yet.
Recruitable means that you can recruit alveoli. So as you saw the alveoli pop open on that video of the pig lung, that's recruitable. We were recruiting alveoli. So we were
making them useful again because they can be popped open and have some gas exchange.
Exactly. So those, you get the bases of your lungs get atelectatic, and if you can utilize that lung, you're going to be able to better oxygenate and ventilate because you've got more surface area to do that from.
So half these people had parts that needed to be popped up again, and half these people didn't, and just needed a ton of oxygen.
They just need a bunch of oxygenation because they've got the way the COVID has attacked them. Their lungs aren't like heavy. They don't have a bunch of water in them. They haven't collapsed. They're just not exchanging oxygen appropriately, just due to the way the disease was attacking them. Versus others were looking much more like a classic ARDS picture, where their lungs were heavy and wet and collapsing. So there were sections of their lungs that were becoming consolidated.
And then the extra pressure would help push that off.
Exactly.
So
100%. Yeah. No, I mean, so the classic ARDS patient, like before COVID,
before COVID, yes.
Before COVID, yeah, BC. The classic ARDS patient that I took care of all the time going into University of Maryland for ECMO was super PEEP responsive. So we could turn their PEEP up to 15, 18, 20, and they would oxygenate, and we were able to get some of their FiO2 down. Versus some of these COVID patients, they look like ARDS patients from their chest X-ray, CT, and just their clinical presentation, but they don't respond to the ventilator the same way, which is frustrating, right? Like, I know how to take care of that. Why isn't this working? Like, and it goes back to kind of my point of, like, every patient is different, and the ventilator is very much one of those things. And it's why we have an entire profession dedicated to doing this. You have to individualize these patients. Like, every patient responds to the ventilator a little bit differently. Even people that you think would be, they're the exact same weight, they're the exact same size, they're the same gender, that whole thing, they are going to potentially react very differently just based on the way their lungs are going to react.
Which is why it's definitely important to know a little bit about what's going on with that screen as your nurse.
100%.
Even if you don't get to press any buttons on it, it's definitely important to know. So this leads me to our last topic. I think we covered pretty much everything else. Your most common vent alarms and what you should do about them.
Sure.
Because the thing yells at you, and the RT's not always there. Like, you're the first one in the room generally.
No, absolutely not. And your first video, you talked about, like, there's two things on the ventilator, two buttons you need to know about on the ventilator. And really, if you ask a respiratory therapist, those are probably the only two buttons they ever want you pushing. And depending on which one you talk to, they may not even want you pushing those two buttons. But keep pushing those two buttons, the alarm silence and the FiO2 boost, or the 100% FiO2 kind of suction, is how I used it most of the time. Or, like you said, we're about to roll the patient, here, have some oxygen type of thing, because I know you're going to desat as we roll you around. But the kind of four big alarms that eye and that are valuable that you should know are a high pressure alarm, so a high peak inspiratory pressure alarm, a low pressure alarm, a low minute ventilation alarm, and a low tidal volume alarm. The other one that you might run into is like a oxygen failure, but that's going to be an issue of like, I don't know, you ended up like that hospital in New York where the oxygen couldn't keep up, or let's say for some reason you're on a tank and the tanks run dry,
Which hopefully you're not, but
which hopefully you're not. Yeah. Or for some reason, and this is going to be super rare, the connection on the wall has come out. Like it got bumped, or most of them are screwed in, but a lot of them are like you have to push a button and the whole like connector pops out at you. And I could see that happening, like you're back behind the bed or something, and somehow that gets pushed. It's usually not that easy to do, but you bump it, it cracks, whatever. You end up with a low oxygen supply alarm. That's something you need to go get somebody pretty quickly about, particularly if you're on a high FiO2. Because unless you know how to go from the wall to the tank, that's typically on every ventilator, which is simple, but it's something that you have to know how to do.
Yeah.
You need to get some help pretty quickly to be able to move to another oxygen source. It's a very simple alarm to fix, but you have to know how to fix it. So we're going to go back to the
alarm I'd leave ringing.
Yeah, and like poke your head out the door and be like,
hey,
hurry the hell up. Pushing the call button and like send RT fast. But yeah, we'll go back to the other four. So the big one is going to be the high pressure alarm, and you're going to get, that's a very common alarm. And it's a lot of times a nuisance alarm, I guess you could say, but it's an alarm you never want to ignore because you want to make sure that it is a nuisance alarm. So high pressure alarm most of the time is going to be the patient coughing, or the patient rolling around or plugging their tube. Now, if you get a constant high pressure alarm, you have either mucus plugged or there's something causing their pressure, their resistance to go up. The rapid high pressure alarm is they mucus plugged, they're biting their tube, their tube's kinked, right? So this is a little less common in adults than it is kids, where their tubes are super floppy and it'll flop over. But still, I've seen tubes like flop over, or there's usually a lot of stuff hanging off the tube. Like, so you've got an HME, you've got the suction, whatever. And let's say you're rolling them and the tube folds over. Something like that is anything that's going to cause a resistance to the ventilator putting pressure in is going to be your high pressure alarm.
Proning and your patient has slid down in the bed, that's one of the things that could kink it off.
Yes.
Another one, I had a high pressure alarm and I came in and my patient was seizing, which was making them clamp down on the tube. So definitely a nuisance alarm, but definitely important.
It very, very commonly is a nuisance alarm, and this gets people into trouble because they're like, oh, he's coughing again, and no, he's having a seizure and he's trying to bite his tube in half or something like that. So high pressure alarms are probably the most common alarm, and unfortunately, because they are the most common alarm, they cause a lot of alarm fatigue. But I would caution you to not ignore a high pressure alarm unless, like, go in, even if you just go to the door and you're like, oh, he's coughing, and then you walk away, but confirm the reason that it's alarming. On the other end is a low pressure alarm. And a lot of times you're not going to get a low pressure alarm. You're going to get a lot of these ventilators are aware of the difference between a low pressure alarm and a vent disconnect alarm. Because the biggest reason you're going to get a low pressure alarm is that the ventilator became disconnected. Whether it became disconnected at the ventilator or at the ET tube, the tubing has come disconnected from the machine. So you have a leak in your circuit. So once again, low pressure alarm, important.
Your patient's not breathing.
You can silence it, absolutely. And this is these are alarms that you can silence. And my first step is not to troubleshoot the alarm. My first step is to silence the alarm so that I can think and then troubleshoot it. But don't silence and walk away. Like, by all means, the first thing you can do is hit silence, but then you want to interrogate why you're alarming.
Right.
So that's sort of a low pressure alarm. And then the last two, your low minute ventilation and low tidal volume alarms, sort of go together. And a lot of times, and this is where it gets a little bit, where alarm fatigue can kick in. If you get a high pressure alarm, a lot of times you'll get a low tidal volume alarm, right? Because the breath was a low tidal volume because they were high pressure limited. Because you've got a safety feature built into almost every ventilator, actually every ventilator on the face of the planet that I'm aware of, in that your high pressure alarm limit is also a pop-off valve where the ventilator, you hit that high pressure. So let's say it's set at 50. If you hit 50 centimeters of water pressure, the ventilator dumps the exhalation valve. Like, it opens the exhalation valve instantaneously to dump the breath so that you don't overpressurize your patient.
Pop a lung or something.
Exactly. So what's going to end up happening is it's going to go in, the breath's going to go in, it's going to high pressure, it's going to dump the exhalation valve, and you're going to get a 40 cc breath. So that's going to cause the low tidal volume alarm to go off. If you get enough of those in a row, you get a low minute ventilation alarm that goes off. Because minute ventilation is tidal volume times rate. So if your minute ventilation was 10, a lot of times we'll set, and it depends on what the protocol is at any given hospital, but you'll set it a couple liters below that. Well, if I miss 4 breaths, depending on what my tidal volume is, I might have lost anywhere from 1.5 liters to 3 liters. So that's going to cause the low minute ventilation alarm to go off, which is fine. And you just have to know why that alarm is going off. You say, okay, well, they high pressured, so that's low. It'll come back. And you just want to kind of stand there for a second and say, okay, what's the next breath? What's the next breath? And the minute ventilation, you'll see it fall off and you say, okay, well, now they're breathing okay again. That'll come back up. And so it's just sort of understanding why the alarm's going off. Does that sort of answer your question? Was that sort of what you were after? Okay.
Making sure you know the reason for it. So it's like, my breath was blocked, so I didn't get the next one, so the volume was low. And if you're not getting successive ones in a row, then your entire minute ventilation will be off.
Yeah.
And if it's not fixed after that, you have a problem.
Yeah. Yeah. I mean, it's just sort of understanding what the ventilator is doing and why it alarmed, and then kind of being cognizant of what's happening next and how you've addressed it. So were they coughing? Okay, now they're not coughing. Everything's back to normal. And their minute ventilation alarm may be going off, and you can hit the alarm silence button because it'll come right back. Give it 30 seconds and it won't be alarming anymore.
Especially if you let your patient go back to sleep by not letting that alarm ring.
Exactly. So it's all about sort of understanding what's happening and how the ventilator is doing it and why it's alarming.
Makes sense.
I think that was that everything we wanted to talk about?
I think it is. I can't think. I mean, there's so much to the ventilator to talk about, but I feel like that's a lot to digest in one session for sure.
Yeah, I have no idea how long we've been going, but
hot minute, I don't know.
A little while. But I mean, that's sort of the down. We got a little bit into the weeds, but not too much. But that's what I would want to know if somebody came to me and said, "What do I need to know as an ICU nurse on the ventilator?" Those are the big things. You need to kind of understand what the settings are, where to find the settings, and ask questions about why they're on certain settings. So
exactly,
why is the PEEP where it is? or why is the tidal volume where it is, or why is the rate where it is. And
and there's not one setting for
no,
everyone. I like that point that you made, because it's super important. Like, not everyone gets a rate of 12 and 450 tidal volume and 40% FiO2.
no, and there are ways that, and we won't get into it tonight, but there's ways that we decide, okay, how much, what's their rate, what's their tidal volume, like how we decide on that and what's safe for each patient and things like that. And the other thing is that for a lot of patients, it doesn't matter if they're on pressure versus volume. And particularly with some of these ICU ventilators where you can finagle the way the flows get delivered, I can put them in volume and finagle the ventilator around where it is delivering the gas like pressure. So that's the good thing, but also the complicated thing about mechanical ventilation is that it's very individualized for every single patient, and it's also very individualized to every single institution. A lot of
That's
you
true.
can work at one institution and go to another institution, or even you can work in one ICU in one institution and another ICU in that same institution, and the ventilator philosophies will be very different.
Yeah.
There's a joke that when they graduate like intensivist school or even med school, and not quite med school, because let's be honest, like an intern has no idea how to run a ventilator. But the intensivists, that there's two lines to get your diploma. One is pressure, one is volume, and the two never cross. And I think it's pretty true. Like, there's a
Yeah.
lot of places that just prescribe to volume ventilation, and there's a lot of places that prescribe to pressure ventilation. And I have not seen to this day a shred of evidence that says one is better than the other for mortality. Now, there are certain patients that, in my opinion, and based on literature, do better on one over the other, based on their pathology. But for the vast majority of patients, it doesn't matter which one you put them on. They may be more comfortable on one versus the other, but in the long run, it's not gonna be the end of the world whether they're on one or the
Right.
other. And the modes are confusing because they're all different, and every ventilator has them different. And if you have an institution that decides on one ventilator across the entire institution, that makes your life a lot easier, because then you're looking at the same ventilator everywhere you go and in every room. There's a lot of institutions that bought 5 of these and 10 of these and 20 of these. So it's sort of a crapshoot, and it's whichever one was free and ready and whichever one the respiratory therapist grabbed out of the supply room. And that makes things even more difficult. And then during this time period where you've got COVID and we're using transport ventilators and the old ventilators, and they're dusting things off that were in closets. And respiratory therapy at Hopkins has actually been running they were trying to break it. Like, they were running it in a supply room. It's like a little tiny pneumatically driven plastic ventilator. It almost looked like a BVM kind of, but no bag. Like, it had a valve in it, and it was pneumatically driven, and it basically had a timer that would flick a valve. And so that doesn't have waveform, it doesn't have settings, it doesn't have anything. But like, ventilators are at its very basic core, they're that simple. They are a gas source and something that opens and closes a valve at a time, like at a time interval. So it could be as simple as that, or as sophisticated as the Draeger Avita or the Hamilton G6, I think G5, G6, whatever it is these days, that can do everything and anything and have esophageal balloons. And there's one ventilator that has a setting that you can turn on that will wean your patient and do the SBT, and then a screen pops up that says, please extubate patient.
Oh my God, that's
like,
insane.
That's the spectrum of ventilators out there.
Wow. So it's important to kind of know what you're looking at.
Exactly.
Even if it does everything for you, at the end of the day, like, you're still the one that's supposed to know whether your patient's getting sicker.
100%. And like we said, what seems like 4.5 hours ago, you're the eyes of the patient or of the provider. So you're the one in the room. You get to kind of see what's going on. Don't treat the ventilator like a piece of office equipment in the corner that somebody else takes care of. Get familiar with what it's doing,
Yep.
because it's attached to your patient and it affects a lot of what
Yep.
you do, right? If the PEEP's up through the roof, it can crap out your hemodynamics and you're going to need more vasopressors or you're going to need more fluid.
Yes.
So it's just as important as the CRRT machine and the pumps and the feeding pump and all that other ICU equipment.
All the ICU gadgets.
All the ICU gadgets. All the stuff that I disconnect when I come and transport your patient.
Yes, run off.
I'm like, can we take that off? Because no.
Is it really important?
Is that really important?
Well, thank you for your time.
Yeah.
I do appreciate you taking so long to discuss this with us today.
No. I love this stuff. I'm happy to talk about this stuff.
I think my philosophy in nursing has always been to surround myself with people who make me feel dumb or make me feel like I only know like 2% on a topic. And I definitely, you're definitely one of them. So, and it's always served me well.
Only on this. The rest of it, I don't know what the hell I'm doing. Like, okay. I am completely clueless with everything else.
I don't believe that, but
somebody told me something very early in my career, and it has served me well. If you're the smartest person in the room, you need to go find a new room.
Yes. No, exactly. Yeah, that's kind of
I'm sure they ripped that off of somebody, and I actually don't remember who told me, because I don't hang out with people that are that smart. So so they couldn't have been that smart.
So they couldn't have been that smart.
But no, that's definitely served me well. Is like, if you're the smartest person in the room, you need to go find yourself a new room. So
yeah.
But no, I'm happy to talk about this stuff, and feel free to put my information out there if people have questions or they want to ask anything. I'm happy to answer it, and we can share slides and videos and whatever else. So
sounds great. Well, thank you. I'll do that.
You got it.
You find your unrecord button.
I'm working on it.